Hello and welcome. My name is Donna Cryer. I am the CEO and founder of the Global Liver Institute, the world's largest patient advocacy organization for liver health. I am so excited to bring you this series. As you know, equity has been and is part of our essential essence. It's not an add-on of the past few years, but something it's core to who we are and what we do. I'm just excited that with this series, hopefully we'll be able to do it even better. Across October, you've been hopefully hearing and experiencing all things liver and all things liver cancer. We believe October is for livers. Frankly, every month, we believe every month is for livers. But here in October, we particularly want to shine a spotlight on liver cancer and liver diseases and how they are experienced by different communities, different patient and caregiver populations, so that we know as an organization and you know as an audience how to respond more effectively, more efficiently, with more empathy and more impact on behalf of and with these communities. And so today I have the kickoff of our series for Hispanic and Latino populations. I cannot think of greater experts to help me bring these stories, these statistics, these issues to light than I have here with me today. I will say in advance that not everyone will be able to be with us for the entire time. So without further ado, we will start. I have Ysabel Duron, who is the founder and president of the Latino Cancer Institute in San Jose, California, where I have family. And I'm so, it's been wonderful to have been able to partner with Ysabel on issues before around health data and governance. I have, as you can see together, Dr. Suzanne Fisher-Hoch and Dr. Joseph McCormick. Dr. Fisher-Hoch is professor of epidemiology at the University of Texas School of Public Health in Brownsville, Texas, and apparently at the same place in Brownsville, Texas, which hopefully they will tell us more, I know, but you all listening need to know about how important this area of Texas is, not only epidemiologically, but to our understanding of how to really address liver health and liver cancer. So Dr. Joseph McCormick is the dean and professor at the University of Texas there. I have Dr. Yvonne Flores, who is a professor of the Department of Health Policy at UCLA in Los Angeles, another epidemiologist with us. And so we will make sure that you are armed with the facts and figures that you know, not only with the humanity of the stories to bring this advocacy forward. And then we have with us Darcie Green, who is the CEO and executive director of Latinas Contra Cancer in San Jose, California as well. It's been exciting to bring some of the geographic diversity to our series. So I say welcome to you all and thank you. I will start in Brownsville, Texas, with the doctors McCormick and Hoch-Fisher. Maybe with Susan, if you'd like to start with us about the main drivers of liver cancer and liver disease as you see in your community.
Yes, we've been working here since 2001, actually. And when we first came here, we realized there were no data, essentially, on the community. And so we set up a cohort in order to establish some solid prevalence data of important diseases, principally diabetes and obesity. And as we went on, we became aware that liver cancer and liver disease were in fact important in the community. So we pursued that for a while. In particular, for instance, some of our counties down here have rates as high as 16 per 100,000, whereas the US rates, last time I looked, were about 9 per 100,000. So very, very much higher rates in these Mexican Americans than elsewhere in the US. So we set up a prospective study of the cohort, and in about 2000. and 15, 16, we started to do elastography. And we have now done elastography on more than 1,000 people. And we are now in a follow-up one with several hundred. And we're seeing very high rates of hepatic fibrosis. Some people come into our cohort with KPAs that's in the range of cirrhosis, and they don't know there's anything wrong with us. In the local clinics, they'll say, oh my goodness, liver disease is a really big problem. We hear that both in the federally qualified health centers and in one of the hospitals. Recently, we were talking to one of the physicians there, chief medical officer. He said it's a massive problem. So basically, all I'm telling you is that chronic liver disease, NASH, NAFLD, is a massive problem in this population. Joe,
just to comment further about that. So our cohort is are randomly selected people from the community. So it's not focused on any disease. And because it's selected randomly, we can measure prevalence. Sue and I are physicians, epidemiologists, and are learning all about the genetics of some of these things through our cohort and our collaborators. But one of the things that we did when we realized the importance of potential importance for liver disease was to look at in the hospitals and the clinics to try to identify cases that had been reported for liver disease. And lo and behold, the rates overall of liver disease was about 220 per 100,000, very high. And what was striking about it is that those people with liver failure, we had 4 people who, I believe it was 4 out of all the numbers that we looked at, that had any chance of liver transplants, and no one got a liver transplant. So not only do we have a lot of disease, but we have very little access to, first of all, we have little access to diagnosis. And until more recently with the ultrasound, use of the ultrasound, this depended very much on liver biopsies. Those are complicated. And since 40% of our population has no health insurance, including federal health insurance, this means that a lot of people were excluded from any chance of a diagnosis. And so I want to point out that liver cancer, yes, is high here, but it's only the tip of the iceberg. Liver, if you talk to people here, they all have relatives who had cirrhosis. And when we look at our data now over these years of following up, so our study is longitudinal, 80% of the liver disease that we measure is from obesity, related to obesity and diabetes, not to hepatitis virus nor alcohol. About 20% are associated with those. And we've measured those very carefully. So what does that say? In our population on the border, huge amount of liver disease that people are completely unaware of, and the community as a whole is not educated at all about looking for liver disease or thinking about it.
Yes, I think that unfortunately is a wonderful way to set the stage for this conversation and why it's so important to have. Maybe I'll follow up with Dr. Flores to help us continue to give a context for why this is so important to have this conversation with and about Hispanic and Latino communities.
Sure. I'm happy to talk about some of the major risk factors or contributors to this problem among Latinos, which I don't think is anything new. It's just something that is maybe not being addressed as aggressively as it should be, because these are risk factors that have existed for decades. It's just that they just keep getting worse and worse and worse. So as all of us, I'm sure, know, but maybe not necessarily.
But our listeners don't. And so many people that I talk to don't.
Yes. So just so that we get the word out, Latinos in the U.S. have the highest prevalence of binge or heavy drinking compared to other races and ethnicities, including Asians, Blacks, and whites. So recently, we examined NHANES data, which is the National Health and Nutrition Examination Survey. So we examined data from 1999 until 2018. Unfortunately, they don't have data that covers through our COVID years. So it's just before COVID. And we found that the prevalence of binge or heavy drinking was highest among Latino males. And we found a prevalence of 67%. So roughly 2/3 of Latino males are reporting that they are engaging in heavy or binge drinking, according to this survey, which is nationally representative. And these numbers compared to Asians, who have the lowest prevalence of heavy or binge drinking, which is 30%, or among Blacks, it's 45%, and 54% among white males. So we're seeing, in some cases, like a heavier binge drinking that's twice as high among Latinos than it is among Asian males. And among Latina females, during the same time, we're also seeing the highest prevalence of binge drinking, which was estimated to be 43%, compared to 25% among Asian women, 32% among Blacks, and 36% among white females.
And
Now,
did those rates rise during the pandemic? Because many people note that when you keep liquor stores open and you close churches, you're inevitably going to have a problem. And we see the rates of all types of liver disease rise, those both related to alcohol and those, as we heard, that don't. So have these changed?
That's an excellent question that we will be able to answer. And anecdotally, supposedly there is some data that show that there have been more emergency room visits and that there has been an increase in alcohol consumption. It's just that we don't have nationally representative data for that would explain or conclusively allow us to determine how much more drinking has gone on during the pandemic. But the most recently available data, which is through 2018, we do have some good news, which is that for all races and ethnicities, including Latino males, there was a significant decrease in heavy or binge drinking from 1999 to 2018. All races and ethnicities, including Latinos. However, among females, these rates only were either stable or they decreased only slightly, except among Asian women who had much lower heavy or binge drinking rates in 2018 than they did in 2019. So we did see a marked decrease in drinking among Asian women. So that's one of the major risk factors. And if you ask pretty much anyone off the street if alcohol is related to liver disease, they will say yes. However, not everyone is aware that obesity is a major risk factor for liver disease. So that's something that people still need to be educated on. Obesity is definitely a risk factor for multiple diseases, not just liver disease. And most people know that it's associated with cardiovascular disease, that it's associated with diabetes and even some cancers. But if you ask random people off the street, they will not, and we've surveyed Latinos about this. Mm-hmm. And I think we found something like 60% of Latinos were aware that obesity is directly associated and a risk factor for liver disease. So there isn't as much knowledge about the risk of obesity and liver disease. So I also have some statistics about obesity and the prevalence.
Well, how about we get to those? We get to those in just a minute, because I want to put this in a context. And so one of the things that's most striking to me is that 1 in 5 liver cancer patients in the U.S. is of Hispanic descent. And we know that the survival rate for liver cancer is less than 30%, usually less than 20%, around 18%. And that's for everybody with access to the greatest insurance and the greatest healthcare. And so, Ysabel, as you work on cancer issues, how does liver cancer and one of the few cancers that is rising instead of declining, how do you put these liver cancer numbers in context with your work with other cancers?
Well, Donna, I am a journalist by training, so I love the data and the facts.
Mm-hmm.
I usually know a little about a lot of things, which is why I always ask the experts. So I went to talk to a colleague of mine who's at the University of Arizona, Associate Professor David Garcia, and he is very much focused on liver cancer and non-fat, non-alcohol liver cancer, liver disease. And he was telling me something that really astounded me that I hadn't known. And I don't know if Doctors McCormick and Fisher-Hoch have seen this because of the prevalence they're talking about on the border. It doesn't surprise me anymore, doctors. But you know, there are 62 million Latinos in this country, and 63% of those Latinos are Mexican. And what they have discovered is that 50% of Mexicans on this side and in Mexico of this border have an allele that predisposes them to have fatty liver. So it's in the genes. Already they're at risk. Then you add in poor lifestyle, lack of exercise, and other components of, you know, food deserts where you get bad food and not healthy food. So nutrition is bad. You have the combinations of obesity, you have diabetes, and then you add in this extra component of risk, because there's also predisposition to diabetes. Connect all of these dots and you've got a bad outcome. And right now we have statistics that Mexicans are about 50% more likely to die from liver disease than whites, and that's according to the CDC. I look at the person as a whole person and not just as pieces and incidents. So part of me tries to address all of this by exactly what you inference. And I think what Doctors McCormick and Fisher-Hoch are also trying to point out, and what I think Darcie needs or does do at the local level, and that's education, education, education. We did it all the time. We used promotores to raise the awareness, guide them into clinics, and try to get, you know, whatever medical care is needed. The bigger issue on that end, and once again, I think our good doctors on the border pointed it out, there are huge systems barriers to health access and to get to the final kind of care and treatment that they need. So we can start with education. We can raise this awareness. We can tell people they possibly have a killer in their system. And then we put them in the hands of systems that can't handle the burden, because they also have, you know, they're under-resourced, because you talked about clinics, talked about federally qualified health clinics. They're under-resourced as it is, and they can barely have genetic counselors on hand to do any counseling, and particularly in Spanish. So there are a lot of issues, and those are the things that I'm working with at the state and the federal policy level to remove those barriers. So we can have partners on the ground doing the education and raising the awareness. We can remove the burdens and the barriers for clinics who get most of these customers, if you will, and we can change the nature of outcomes for all of our people. And if we remove those burdens and barriers, it will happen for all vulnerable populations and not just for Latinos.
I think that is spot on. It's why GLI has Spanish-speaking staff. It's why all of our materials on non-alcoholic steatohepatitis or NASH or fatty liver disease are in Spanish. It's why we're having this roundtable, and why we have such a large policy team to, because it would be a horrible disservice, I felt, that if we brought you all together and you identified all the things that we should do, that we didn't then pull them through with the policy support to make them possible. And so I want to get to Darcie Green, and I'm so honored that someone who works on with women in cancer would come and spend time with us in October. To be embraced during this month that is otherwise awash in pain is really something that I feel so honored about. And I think that the support of healthy women, of Latinas Contra Cancer, of letting women know that this is an issue that pertains to them is so important. How can we get people screened when people think that perhaps that mammography is the only screening that they need to do? Darcie, how can we bring women along to understand that this is a cancer that they need to know about for themselves and their families too?
Yes, thank you so much for inviting us to be here today. We could have a whole conversation about pink washing. At our core, our health justice organization. And I want to start out by saying, not only is Ysabel the founder and president of the Latino Cancer Institute, she's also the founder and long-serving executive director of Latinas Contra Cancer. So our organization would not be here if not for Ysabel's personal journey with her own cancer experience and her knowing way back when, almost 20 years ago next year, that being able to predict and foresee and her experience being so grassroots in the community and understanding what the needs are. And as Ysabel can tell you, we've come a long way in many places, and so many things are still the same. And so at Latinas Contra Cancer, at our core, we're a justice organization, because how could you not be when you are serving the needs of the Latino community on issues of cancer and health? And our organization serves both men and women. And yes, in this month, we do talk a lot about breast cancer, so we are talking about breast cancer. But when I think about, and much of what Ysabel was saying earlier, when I think about the work that we do at Latinas Contra Cancer, we do focus a lot on individual behavior, right? And making sure that people know how to lower their risk for certain cancers, know what individual behaviors they may be able to stop or start in order to lower their risk for cancer, that they know what screenings are available to them, and then we help them navigate through that, right? If there are barriers, or we can help them with transportation and other things that they might need. But after nearly 20 years of doing this work, as a service provider, we've realized that our ethical response to health injustice really has to be a lot more than that. And so we think about individual behavior, but also in this context of systemic injustice, and how you really can't individual behavior your way out of these health disparities that exist, because so many of them are systemic. And so when we think about how we are helping people to overcome these things, it's really also shining a light on these healthcare systems that really are not set up to adequately meet the needs of Spanish speakers, undocumented folks, people who have these barriers. Earlier it was mentioned food deserts, and we also now have heard the term food swamps, right? Where there's people who are in areas where there's lots of choices on what to eat, but they're very limited. So one of the things I wanted to speak about were some of these systemic changes that we would like to see, that we think are really important, especially when you remember that health disparity is not a natural occurrence, right? This isn't just like an organic thing that our community is so disproportionately impacted by this cancer and other cancers, right? And that the prevalence of cancer in our community sets off a ripple effect into someone's life. And that's what we deal a lot with at Latinas Contra Cancer. It's not uncommon for a Latino cancer patient to lose their housing, lose their income, lose their insurance, have this big economic stress that also then leads to late detection, problems in survivorship, and other really bad adverse health outcomes that can impact our community generationally. I know there was going to be a question about potential policies. Is this that question, or should I wait for...
You can answer that now. I think that
okay,
this
great.
is a natural flow.
Great, wonderful. So some things that we think about that can really help if we're transitioning from individual behavior, which we've talked about a little already, and to what systemic things we really need to be thinking about, is definitely the expansion of Medicaid, Medi-Cal if you're in California, but Medicaid. Those income limits need to be expanded. We need to adjust based on the pandemic. So many people saw generational wealth wiped up. So many people saw income wiped out. We really need to think about expanding Medicaid. We also, in that conversation, need to be very intentional and push to expand health insurance for undocumented folks in this country as well. In California, we've been doing that. Hopefully, I forgot which year it will be, but all people will be covered under subsidized care through our government. And we need to make sure that all residents who live in our country have access to Medicaid or the services that they need in order to get healthcare. We're all better off because of it. We are supportive of guaranteed income pilots, housing and rent subsidies. We know that these things are really important if you want a patient to be able to prioritize their care, prioritize their screenings, prioritize their treatment. They have to be able to have stable housing. They have to know how they're going to feed themselves and their families. And a couple of other things is we're seeing now that the increased professionalism of promotoras and healthcare workers, two separate things, but healthcare workers. So increased continuing policies that allow organizations to seek out reimbursements for this type of work through Medicaid or other insurance plans, so that we can continue to build a pipeline of promotoras and also community healthcare workers that can be out there building trust with community, who know what's going on in our neighborhoods, who can help them overcome these barriers, but also help change these systems. And then lastly, increasing the pipeline of Latino professionals into healthcare. So often we hear from our community that third-party translation has fallen a little bit short, or third-party interpretation has fallen a little bit short, or other barriers that they face by not having someone who either has their lived experience or shares some commonalities with them as far as their ethnic background and or country of origin. So we need to make sure that we are increasing the pipeline of Latino professionals. And in another question we have later on the road, I want to talk a little bit about the work we're doing around mobilizing and organizing patients, because we also firmly believe that while the Latino community is often asked about what racial disparities exist in the area of cancer or in the area of health, we are not often at the table when the solutions are being made. So as a matter of principle, we believe that patients who are most impacted by these health disparities in the area of liver cancer or others should be the ones not only raising these disparities, but also developing the solutions and partnerships with hospital systems.
Absolutely. Please, Doctor.
I'd like
Dr.
to move
Flores, go
this
ahead.
to a slightly different direction, in the sense of, here is a disease that we know is increasing. Yes, there is a single PNPLA3 that is associated, but it accounts for a very small amount of cancer. One of the things that we don't have is any treatment. We have no treatment except for prevention. The general kind of mantra of prevention, of do this and do that. We have programs here in the Valley where we are, that we run, that address prevention of diabetes in thousands of people. So we know that that is something that is important. But in this case, we also need clinical trials. We need to understand the disease.
And specifically in NASH, is that what you're talking about with no treatment?
Yes,
Clearly there are liver.
We're talking about NASH.
But in NASH, okay.
For viral hepatitis, there's treatment. For alcoholism, that is a whole different issue. But for us, the alcohol and
that's small.
and viral hepatitis make up less than a little less than 20% of the attributable risk for liver
Actually,
disease.
the biggest attributable risk is, in fact, raised blood glucose, not obesity. And in our analyses, that's quite clear. So uncontrolled diabetes is the biggest driver. Metabolic abnormalities, uncontrolled lipid abnormalities are the biggest driver of liver pathology. And that liver pathology is the continuum in which you develop cancer. And Dr. Montgomery is absolutely right. If you go to the clinics, basically, what can you do? You tell Mrs. Gonzalez, well, your liver doesn't look very good, and I can't do a FibroScan because I haven't got one. And you know, I'm not going to do a biopsy because it's dangerous and you may bleed, which they do. So why don't you eat a bit less? Big deal. So she goes off and you don't see her for 6 months. And so the physician has got no tools at all to help this lady. Mind you, a lot of these patients are women, not men in the society. They have no tools, no medical tools, not.
So what we are involved with our clinical translational science program at our major university in Houston. And this is a program that is really focused on trying to get minority populations, and 93% of our population here is Latino. And I'm using that term as opposed to Hispanic because we know Hispanic is a lot of different, but we're on the border and most of the people come from south of the border. And so one of the things that we are really focused on, and by the way, we use promotoras extensively for almost everything because they know how to talk to people. We are just a couple of old Anglos, and that's not our forte.
But you're smart Anglos. You're smart Anglos. You use promotoras.
Oh yeah,
We've been around.
We've worked in Africa, Asia, all over the world, and I can tell you that If you don't try that and you try to do it yourself, you're doomed. So the point is that we really are focused on getting our population to participate in our clinical trials, in our clinical studies, because that's the only way we're going to get into the depths of the metabolism and all the other things that are driving this. And it's not all about diet and physical activity, folks. I wish that were the magic bullet, but it's not. And so we need, for example, we are now uncovering genes associated with morbid obesity. 10% of our population here is morbidly obese, not just obese. 50% are obese, 10% are morbidly obese. And that's something we measure in our clinical research unit. This is not a self-reported trial. We bring people in and measure everything. So including using the fiber scans and all of that. So this is where we really need to go, is to get people into clinical trials so we can understand the disease.
And the other issue is we are focused on prevention.
Yeah, hold on. Can we just hold on? Let Ysabel would like to comment, and I'd love to have this cross conversation. Go ahead.
I like what you're saying and where you're going, and to me, it's really critical that we do much more definitive testing. But I was talking to Dr. Garcia about this, and I asked, there's morbid obesity and all of these other issues. How much do you think that stress and trauma, particularly with Latinos and particularly on the border, and particularly with all of the political messages they're getting, drives some of that obesity, some of those bad habits? I just can't believe that doesn't have stress-related impacts that drive other things. And so when you're facing this trauma in your life, I guess you don't even you stuff it, right? So you eat it. Now, how much of that is genetic? How much are you drinking? But in this case, we're talking about non-alcoholic fatty liver.
Right. So let me ask it this way too. I want to build on that and talk about how do the promotoras sort of start to have the conversation with people about their weight, particularly in cultures where being at a little higher weight is not the negative that it is perhaps in other cultures. And so how do they have that conversation about weight? And then to the points that both Yvonne and Ysabel were making about the causes, the drivers for their weight, at least the individually controllable factors.
Yeah. So I can tell you that our promoters all are trained in motivational interviewing. And we probably have at least 75 or 80 promoters just in our little program where we only have 7 faculty who are out in the community every day, and they're all trained, 1 in diabetes prevention and 2 in motivational interviewing. And you're absolutely right. That's one of the ways of doing it. But I wish that it were all. So there is someone in your area who is at Hope Cancer Center, Dr. Seawald, Dr. Victoria Seawald. She recently published a study that addresses part of what you're talking about, Ysabel, and that is she looked at, and she works in a Latino community in Los Angeles, and she looked at people who live in areas that are either redlined or divided by highways, all of the social determinants that we're all familiar with in terms of housing, just what you were talking about earlier, all of those issues. And she asked the question, what are the markers of stress in these people compared to those who live in areas? And indeed, they all have high markers, but it's, once again, this is a clinical trial. It's not just going out and gathering the information, the data, and speculating. She actually measured levels of the markers that we know to be levels of inflammation, which is really important in stress, and indeed they're higher. So there's no question that that's part of the issue. Now, we know Dr. Garcia quite well. In fact,
I mentored him.
Sue mentored him with his grant, so we know him quite well. And so his interests are relatively limited to self-reported and a little bit of measurement, but not to the level of where we really start to get into the understanding of this, of what's driving this. but no question, social determinants are certainly important. Absolutely.
And
So
one of
let
the,
me,
add-
yes, I
sorry.
was coming to you for part
Yeah.
of it. Like my question will be the trust that's needed to engage in clinical research. But you also answer the question that you wish I had asked.
Yeah, no, I mean, trust is such a very important thing, right? Many of the folks who come to us at Latinas Contra Cancer as a CBO have come to us because they either have no relationship with a healthcare provider, they have no primary care, they have no OBGYN, the first time they're interacting with the healthcare system is because something has gone wrong, right? And they need to have this interaction. And so they haven't had a relationship with somebody. Or they've had something bad, a bad relation. Something has happened. Either they've been mistreated, or there was some disconnection in care, disruption in care. Something has broken along the way, and then we help to kind of like bridge that gap. I was sitting there like cheering as Ysabel was speaking about just us considering these other things, because I think you have to consider all of it, right? I mean, you have to consider all of it. And we can't have these conversations in absence of the fact that social inequality is literally killing us, and racism and the racism that our communities feel, and the trauma of poverty. And there are, as you mentioned, many studies that show the impact to one's body. I understand there are clinical trials very specific to the gene that you're talking about, but in the community-based and participatory research that we've done, and certainly anecdotally, and very much in the trusting we have of people's lived experiences with this, we know that deeper than just social determinants of health are the very intentional ways these social determinants of health conspire against already marginalized communities or minoritized communities. And so we want to look at it from all of these angles of how are we increasing our participation in the research, and we know that does take not only trust but also removal of barriers to participating in clinical research, and we know many of them exist, and also helping to rebuild trust, because for very good reason there are some communities that have lost faith in the practice of research and science in our communities. So we have to, one, honor that there are some populations in some portions of our community that have they have memory or passed down memory of malpractice or other things that have happened in the field. And we have to address that, build the trust to say, that this is important, remove barriers, but we also know that we're also less likely to be asked or offered clinical trials, right? So how are we educating medical providers to even offer that when we know that our community is just less likely to be offered or invited to participate in clinical trials? So the issue, though, of how the traumas of poverty and racism and politics and social inequality impact our community uniquely with regard to our behaviors and with regard to how those behaviors show up for us physically is something that we really have to think about. And that brings me to this other point that I didn't mention during the policy suggestions, but it was one that I left out, is universal medical or mental health care, right? Is how, so our community is experiencing all of these social traumas, which are leading to adverse health outcomes. And really what we believe are choices as consumers or choices as people who live in communities, it really aren't really choices, right? When you think about how limited your access to behaviors are, or how limited your access to clinical trials are, or how limited your access to healthcare is, or what the quality of your healthcare system is where you live, we really have to think about those choices that people have and increasing choices. So we just want to make sure that we're looking at the whole. And for organizations like ours that aren't clinical, right? We're not doctors, we're not formally researchers, and we're intentionally not a clinic. We kind of live in that space where how are we addressing it from this way and trying to eliminate these inequalities that exist that, again, aren't natural occurrences. These are like intentional things that are there with public policy or exist in absence of public policy protecting our communities.
So let's think about that. And I'm going to come to Dr. Flores for how we apply the data to create that policy infrastructure. So one of the reasons why in having this conversation about liver cancer, we're talking about all these other liver diseases, is because we cannot fully address liver cancer. We can't achieve the president's goals for the cancer moonshot without addressing liver cancer, because it is so highly prevalent. It is so disparately prevalent in certain communities, and it is on the rise instead of on the decline. But we know for the most part what is driving it. It's rates of hepatitis B, that for which there's a vaccine that not enough people are getting. It's driven by rates of hepatitis C, for which there's a cure that not enough people are getting. Even people who have insurance or have Medicaid and Medicare, over 70% are still not getting their treatment. As was mentioned, we do not yet have a treatment for NASH or for fatty liver disease, but we're starting to borrow things from diabetes, but people are not getting the things that we know to do, except for in rare cases. So that information and that rise in standard of care is not being spread equitably. And then we have put that in a context where no liver patient of any color or of any descent is being treated like patients with other diseases, because there is huge stigma and huge assumptions about who we are and how we got here. And I say we because I'm 28 years post-liver transplant, so I'm a liver patient too, and had to create an organization of my own to find another patient who was brown like me. And so I think in pulling together a liver cancer agenda where people get equitable care, you all are absolutely right. We need to sort of pull back all the way to access to care of any type. So they have the opportunity to be identified and have their diabetes or cardiovascular disease treated, have vaccination, have someone who might identify the liver disease that is evolving, and then have all the parts of regularly receiving whole person care that results in optimal outcomes, and we don't. And so Dr. Flores, as we put together all of the robust data that you have into a policy agenda, how do you translate this data into actions that move policymakers and those who can make these changes that we've identified as being needed?
Exactly. I feel like my work is really downstream, like where you're just sort of describing the problem.
But you're the fuel for advocacy. And so
absolutely.
I can tell stories of impact, but without your data, it's only it's soft.
Yes, no, we all need to
make it hard.
And I feel like this panel is just like just a wonderful combination of different skill sets, and how it is that we're going to be moving the needle forward in the first place has to do with downstream and upstream and midstream and all of this that needs to get done. I do believe that Latinos are predisposed to having additional risk of liver disease, and not just liver cancer. I mean, I know this is a liver cancer advocacy, sort of like we're talking about liver cancer, and liver cancer is important, but like Dr. McCormick said, it's the tip of the iceberg. More Latinos are dying of cirrhosis or chronic liver disease than they are of liver cancer. It's just,
right.
And I mean, just to add another piece of data, I mean, chronic liver disease and cirrhosis is the number 8th cause of death among Latinos. It used to be number 7, but COVID is now the number 1 cause of death among Latinos, right? This isn't 2020. But among the general population, chronic liver disease and cirrhosis is not even a top 10 cause of death. So there's, like you said, there are clear disparities that affecting Latinos, and they have to do with everything that Ysabel and Darcie said, with trauma and the poverty and the social determinants of health and all of the adversities that Latinos have to deal with. But even among educated, higher income Latinos, we are still seeing Latinos who have obesity and are drinking. So, and these Latinos quite possibly have the PNPLA gene variant that predisposes them to have a greater risk of developing cirrhosis or liver cancer. So again, I know that I don't want to sound like I'm being insensitive about the importance of losing weight and drinking less, but we all need to lose weight and drink less. I mean, and this is a message that we need to be communicating to our loved ones and people around us all the time, because I would like to make a plug for what moderate drinking is. So that, because I think people don't understand what moderate drinking is, what heavy drinking is, and what binge drinking is. So, I mean, this is, speaking of education, like moderate drinking is 2 drinks or less for men every day. So if as a male, you are drinking more than 2 drinks, that is heavy or binge drinking, period. As a woman, if you are drinking one or less drinks, that's fine a day. That's moderate drinking. So women cannot, like, it is not healthy to drink more than 1 drink a day, period. So anything above that is problem drinking. And we're all educated people who are, you know, not necessarily experiencing some of the adversity that other Latinos do in this country. But I think a lot of people don't realize what problem drinking is. And again, I'm not saying that it's easy for people to not drink certain amounts, because we all have coping mechanisms that maybe involve drinking. But these are messages that we need to be communicating constantly to ourselves, to our loved ones, to promotoras. Heavy drinking is consuming more than 8 drinks per week for women and more than 15 drinks for a man. And for men, binge drinking is drinking 4 drinks or more. I'm sorry, 5 drinks or more. And for women, it's drinking 4 drinks or more. So any form of drinking that is more than 1 drink a day for women or more than 2 drinks a day for men is unhealthy and should just, like, it should just be stopped.
Donna?
Well, you delivered that message clearly.
Donna, we're going to have
yes,
to jump off.
Before I just go, what is the one takeaway that you would have for our audience, or for people who are wanting to help Hispanic and Latino patients, perhaps with liver disease, or if they're in primary care, identifying liver disease?
So from our perspective, just a little bit of background. We came here in South Texas, never having lived in Texas whatsoever. And we found a population that was very suspicious of any kind of research. There was no research going on. And over the 20 plus years we've been here, we've completely changed that by living in our community and working with people from the community and educating about the importance of not just, but the importance of information. We all have opinions. We all want to change the world, but we have to do it one piece of data at a time. And if we don't understand the disease that we are trying to address, then we can make all the housing changes and other things in the world, but some of this still will remain where it is. And so this is why I'm saying that it is possible to change people's minds about research. In our cohort, we have over 5,000 people that we have recruited. They volunteer on a random basis to come in and spend hours. They spend hours. We measure all sorts of things, heart disease, liver disease, diabetes, you name it, and we measure it. We don't just ask people if they have it. And so it can change. And these things, along with what you're talking about, policy changes, we can all chew gum and walk at the same time. And so these can go in parallel with each other. We need to learn and we need to advocate, that's for sure. So I think that's the message that I would give.
Absolutely. Dr. Fisher-Hoch.
Yes, I'd like to make it quite clear, we are into preventing liver cancer. And the only way to do that is the longitudinal studies that we are doing. We followed some people for as much as 15 years, and we see them every 5 years at a minimum. We work with MD Anderson, we work with other great centers who do more advanced stuff for us. If we can't figure out what the mechanisms are that drive certain people in this direction and not in another, we are wasting a lot of our time. So the important thing is we identify the at-risk people, and that's going to take some biomarkers. and we are
absolutely
looking
agree.
for biomarkers.
I'm so grateful for the work that both of you do. We all are. I couldn't do the work that I do as an advocate without the basis of what you do. So thank you so much for being with us today, and we will continue this conversation, but I look forward to continuing our work together.
Donna, I would love
Thank
it
you all.
if they would share their research papers with us. That'll give me
Yes.
background for the work that I
I'll
have
give you a quick crib. My
Excellent.
name is Fisher-Hoch, Fisher-Hoch. I'm the only one in PubMed.
Okay.
So
Okay, that will help our search. We'll also
do
put
your
some things
search
in the
on
show
PubMed,
links.
we pull them all up.
We have over 70 papers. We work with MD Anderson with 2 NIH grants on liver disease. So we're pretty well published, and you can look at them.
We'll help people to find you.
I'm carrying your voice. I'm carrying your voices and your concerns in my head. I am going to the White House at the end of the month. And Donna, when I was there for the moonshot, I told the president's advisor there are no macro solutions. There are micro approaches, community to community to community. And it takes an investment in community-based organizations who use community health workers and promotoras who are going to be the solutions, not only to screenings, but the multiple health issues, and including what the doctors McCormick and Fisher-Hoch are doing. I just think the work you're doing is fabulous, and I want to hear more about it, because to me, it's the kind of model that we need to demonstrate. It's not that Latinos wish to stay out of the issue. It is that they are not being asked to join the issue. And that is what we are trying to point out.
I also just want to clarify, that
that's one of the reasons we came to South Texas. But remember, we're in Texas, not in California.
I know.
The context, let me tell you.
No, I get it.
Yeah, I just wanted to add on to really quick before the doctors leave that I also wasn't at all suggesting that we couldn't do both. I really appreciate the work that you've provided. Thank you.
Okay.
I wanted to just add, because I think this is a really interesting conversation around like how and when Ysabel was at Latinas Contra Cancer, she started this National Latino Cancer Summit that really did just what she was talking about, right? Which is trying to marry the community and grassroots work with the research, because for so many people, it is very not accessible, right? It's very, very inaccessible. And so I what I was hearing from our dialogue earlier, and certainly what I was agreeing to or supporting, was needing to also look at these other barriers to this research and this work being accessible to people en masse. And so when people are living in scarcity, or people are living under these traumas, or people are living under these like conspiring determinants, it makes it really difficult to prioritize that type of involvement without these micro solutions that Ysabel has mentioned, right? So clearly, if you have, and they don't always have to be scalable, right? I mean, things don't have to be scalable to be meaningful and important. You can really have micro solutions across the country that meet the needs of that individual geographic location. And so you need to have both, right? You need to have one, the research, the science, the medicine, but you also need to have a really good understanding of those social conditions that make it possible or not possible for people to participate. So it's one, the level of like how those social conditions impact our bodies, but also how those social conditions can put up barriers to being able to even access this type of work.
I agree. I think, I've often been the bridge between those two different discussions. And I want to come back to a point that you had made about ensuring that people from the communities are involved in the design of the research to start. I think if we start there, then we have clinical trials that account for to people have a stable place to live, so that they, before we start talking about, adherence or noncompliance or anything like that, do they have a stable place to live? Do they have food? Are they safe? So that they could possibly entertain participating in the research, or completing the research diary, or the needs of the requests that are made by research. I think we're much more likely to have those integrated into the research and other programs that we do if people, if community members are at the table to design that from the start. So I think that I'm in violent agreement that there is a way to bridge the community focus and experience and expertise and work, and those of researchers as we support in policy. But I want to go to Ysabel. Clearly, this is a complicated story. It's not as easy to say we're gonna defeat liver cancer.
No, it's a lot of layers.
Exactly. So, Dr. Flores has explained, different types of risk that each need different approaches to help people address, their driver. If alcohol is a driver for some liver disease, there's a whole host of supports that need to be applied for there. If food, not so easy for people to abstain from, is a driver, which it is. There are approaches for that. Access to medical care, is a driver of inequity, and there are. But if people don't even know that all of this is happening, how do we tell that story in a way that feels personal and applicable to people, and that they don't hear as, give up your family, give up your parties, give up the foods that you love culturally. And I've heard many a doctor in Texas try to talk to people about giving up rice and tortillas, and I'm like, I don't think that's the right place to start.
Rice and tortillas are healthy. I mean, in moderation.
So how do we help people? How do we tell that story, Ysabel, in ways that people can hear?
And and here's where I'm going to give a plug for media. Targeted media. And
yes.
Media that isn't disinformation, and media that is also trusted, and the media that those communities use, and not just presumption that this is what they use. So getting information from Facebook and TikTok and all of these places, WhatsApp, discovered is huge. And it's really about learning how to target them where they live. So you go, and this in the Black community, where they live, work, worship, and play. So this is what I keep talking about, the micro approach. And it is best known by those community leaders how to approach these communities. But with the help, one, of media, local media, second of all, recognizing they need targeted messaging for different members of those communities. So how do you address your youth to get them to start changing habits early? Recognize that there are issues, they can then help maybe their parents and their abuelitos. So we're hoping it has generational impact. But at the same time, you also want to stop this horrific disease at the very top, where it's happening with these morbidly obese and obese people. And so you have to do multiple attacks and multiple targets with the hope that you're going to meet somebody in the middle. This, Donna, will not be done without pain. People are going, sometimes I like to say, let's scare them straight, like they did taking kids to jails and showing them what life would look like on the other side. Part of me wants to do that, but I've also found that in the system of human beings that we found in Latinas Contra Cancer, when we would host our bingo games to teach about cancer education, that the women themselves became the influencers. They shared their fear. They shared what they didn't know. They learned from each other. They got peer pressure from each other to do things. And I found this, and they also got real support from these women. I remembered one of the most striking examples when a woman said, "Oh, I'm too embarrassed to go show my breasts." And another woman said, "Better embarrassed than dead." You couldn't hear Dr. Flores say that to a woman in a meeting, but you can hear your peers say that. And this is why I've always believed in the power of the promotor and the community health worker, just because. And so we cannot pretend we have a macro plan. We have to target communities, individuals, and we have to look at states, what the policies are and how they help. I think that California just passed a law that clinics can now charge reimbursements for community health workers.
Yes.
they also put in big money to develop a cadre of healthcare workforce. That's in California. I think 2 states have those right now. So there are different states with different kinds of policies. So once again, it's piecemeal. So I try to work at the state level and at the federal level. And what can I take from these best practices to those tables and knock in some heads, literally, no, figuratively. I'm not a violent person, but this is it. You know this. This is a struggle. It's not a short one. And even though we were talking about liver cancer in 2014 at the National Latino Cancer Summit, here we are 10 years later practically, and we're all suddenly saying, whoa, this is a problem. But that, I think, is because of the increasing obesity we've seen in the community and what's driving that. Right.
Well, I think it's also, GLI is 8 years old and we're a little bigger and a little louder now. And we're in more places. And so, you touched on an issue that I wanted to us all to think about, the difference and the connection between micro solutions and macro solutions. Can we do a better job of surfacing the micro solutions that you were talking about, Darcie, but to be able to do them at scale, be able to have a faster replication of, well, what works in what type of community, and can we fund them and fuel them so that they are scaled and replicated faster than people sort of recreating the wheel or figuring out sort of time and time again? Can we do personalized advocacy at scale is my question to you, Darcie.
I think there's a nuance in there, right? Because both are really needed. So when I think of micro solutions and what's working in different communities, it's really taking on the characteristics and personalities of the community. And also a really important thing is it's led by the community that's there, right? So what works and what cultural, not even talking just like ethnic culture, but like what is the culture of that community, right? How do they get information? Where is the information put out? Where are they worshiping and playing and working? All of that's going to be different, right? So allowing for each community to have these strategies that are really built by the community, led by the community, and investing and trusting the wisdom of the community itself is really important. But even through these micro solutions that can flourish all across the country, depending on where they're at, you can have these micro policy agendas or macro policy agendas that serve to fund these things, right, across the country, that serves to kind of baseline what baseline quality of care is, right? So you can kind of raise what quality of care is, that serve to build in what people's basic rights are as patients, right? Or as just people in the community. So they both work hand in hand. There's the policies at a macro level that you can pass that guarantee us these kind of basic human rights, that guarantee us basic patient rights, that guarantee us a basic quality of care. But how those policies get implemented, right? How those policies materialize, how those policies are actualized, or how those values are actualized at the ground level, then are these micro solutions that happen and need to be funded. And those things happen in community. And I just want to put a plug for one program that we've developed. And so we have community health workers. We also have promotoras at LCC. And last year we piloted, and now it's a full program, a program called Defensoras, because we recognize that in addition to the health education we're doing, in addition to the service providing that we're doing, we also need to build the power of patients to mobilize. And so we've brought the same basic principles of community organizing, right, that you would see happening in any other community. And we're applying it to mobilizing patients around healthcare systems, mobilizing patients around disease, mobilizing patients around insurer systems. And I'll tell you, we're graduating cohorts 2 and 3 right now. We graduated cohort 1 earlier this year. And these are all Latina patients who are coming together to mobilize for the purpose of dismantling predatory practices and making healthcare systems more just. And they come up with what their patient agenda is. And one of the, and this is not a cancer specific program, but there are many cancer survivors in it. One of the issues that came out of this current cohort is clinical trials. They're really interested in, and this came from them, right? So not LCC telling them what issue areas they should focus on as a cohort, them using their lived experience, and then them organizing and building power to make that happen. And one of these areas is clinical trials. And so everybody wins, and there are better health outcomes when patients are powerful, when we hold space for patients to, exert that power, when we hold space for patients to be a part, not just be a part of the solution, but lead the solutions. When I think of the micro solutions that are happening, they must be led by people who are most impacted by the disparity.
Right. Well, those are words that I live by. And
Donna, can I pick up on that for one thing?
Absolutely.
Back in 2009, LCC actually hosted a one-day meeting for Spanish speaking to talk about clinical trials to see if in fact there was this resistance. And what we found after 5 hours of conversation and information and talking about clinical trials was there was no hesitancy on the part of the community, which was of multiple ages and not just cancer patients, but family members, etc. There was no hesitation to do something that they thought would be good, not just for the patients, but for their communities. But what they told us about were the barriers to a successful participation in a trial. And I spent all of this time telling pharma and others what we see as these barriers and have many of them changed. I told the FDA that they had to change some of their regulation in order that low-income Spanish-speaking undocumented could participate in these trials. Have they made those changes? So we are talking about both. We're talking about what patients tell us, what we learned from the ground. The ground was my community of practice. That's where I learned everything I now talk about at the federal and the state levels, because I now know where all of those gaps are and how we need to build on policy to remove those gaps, definitely. So there isn't a resistance to clinical trials as much as there's a barrier, systematic barrier.
Just add one quick thing is that, so when it came up in our defensoras cohort, that's what they said actually, was not their own resistance. It was it was actually one defensora who had an experience with a clinical trial and not getting it in time. And so it was one, the barriers, but two, not even being asked, like not even being offered. And wanting to explore, why is that? Why are we not even being invited to have these conversations? Why are we not even being asked? Or why are these asks happening in places we're not seeing them?
Right. Well, I think that your group of defensoras, much like our Advanced Advocacy Academy graduates of patients who want to be involved in redesigning the healthcare system, came to the same conclusion about wanting to be able to be that bridge in their communities about clinical research, but also needing to design the research and the endpoints and the regulatory environment as well. So I would love to integrate those efforts because I think that's so spot on. Dr. Flores, tell us about the research gaps and the questions that you wish that you could answer from either better data sources or the barriers that you face to getting the research questions answered that you need answered.
Well, yes, I also wanted to say, just to follow up on what both Ysabel and Darcie were mentioning about Latino participation in clinical trials, that I do think that things are beginning to change. I think the COVID-19 pandemic has sort of changed people's mindset about the enormity of health disparities. And because vaccines had to be developed very quickly and there was a push to incorporate, diverse populations in these trials. I mean, I know UCLA is definitely now very mindful of being more diverse in clinical trials and has, like, at least at the Johnson Comprehensive Cancer Center, developed strategies to involve more diverse patient populations as part of clinical trials. So that's definitely happening at UCLA. And I hope that that's something that's also happening around the country, not just here. But I am hopeful that is the direction that we're moving in. I am very inspired by also Ysabel and Darcie's comments about how important it is to incorporate communities in identifying barriers and the best ways to develop interventions and programs that will benefit communities, not just in terms of liver health, but just, health in general.
Mhm.
I do think there are multiple barriers as a researcher to conducting some of the research that I'm interested in. I mean, just anecdotally, I've been trying to get a grant to find out what's going on at a biological level with Latinos, looking at genetic risk of liver disease, metabolic, lipids, like very sort of a very biological sort of focus on what's going on with Latinos. And so this is a grant that I've been trying to get for a couple of years now. And at the beginning, I actually was told by reviewers that why was I only focusing on Mexicans, right? Meanwhile, of course, I've justified that Mexicans of all Latinos have the highest rate of non-alcoholic fatty liver disease and are an extraordinarily high-risk population for liver disease and liver cancer, because this was a grant submitted to NCI, the National Cancer Institute. Anyway, I'm still in the process of trying to get it, and I'm hoping that I will be able to get it. But at first they were like, why are you only focusing on Latinos or Mexicans? Why aren't you using like diverse groups so that you can compare them? And I was like, well, because this is the highest risk population and no one's studying the highest risk population. So I do think someone who's Mexican, who's focused on liver disease in Mexicans for, decades at this point, should be, it's okay for me to just be focusing on Mexican, doing research with just Mexicans. That is not a comment that's come up in the latest reviews of this grant. So hopefully now people are like, oh, that's why I do think things are changing. I really do think that the COVID-19 pandemic has gotten people to sort of be a bit more mindful about disparities and how there really needs to be research that focuses on populations that are experiencing the greatest health disparities. Why are Mexicans, of all Latinos, why do they have the highest rates of non-alcoholic fatty liver disease? Why do they also have the highest prevalence of this particular genetic variant, PNPLA3? So anyway, that's something that I'm focusing on in terms of my research. But I also I work with a group of researchers who develop interventions, and I do think that interventions are also needed to solve this problem in terms of how do we get a group of people, Latinos, who are naturally and culturally very interested in certain lifestyles that might not always be the healthiest for them, especially if they are at increased genetic risk. And like Dr. McCormick said, the genetic risk isn't driving this problem. It's the genetic risk plus being overweight plus drinking. Because there's a combination of drinking and being obese, which is the most problematic, especially if one has this genetic predisposition. And UCLA, just to plug my institution, is also moving in the direction of precision medicine and is now providing genetic testing for free for pretty much all of their patient population, or they're doing, they're starting out with a sample. But the idea is that everyone who's a patient at UCLA will someday have access to their genetic results. And so they'll have the information that they need in order to maybe be more informed about what lifestyle factors they choose. I think if you are Mexican, have PNPLA3, are obese, and are drinking, that's like the perfect storm. So, and I realize that there's all these upstream problems that have to do with how they got there, how they got downstream in the first place, right? That all need to be addressed as well. But at this point, what we're dealing with is the massive number of Latinos who are at risk for liver disease.
Right. And that's why this is so important to have. And I think that I want people to come away with, hopefully they've seen us sort of pull back the curtain a little bit about how all of these things work together. So the climate at NCI and at other parts of NIH did not sort of just get better by itself. It's folks like Ysabel and myself trolling them about supporting disparities research with grants, with changes in the education about grant reviewers, so that when you come back with your research proposal, it has fewer people who are going to mansplain to you why that isn't a valid area of research, and are going to recognize that those are important areas and take their cues from you and the other investigators doing that research, knowing that there'll be folks at the top holding them accountable, that we're watching, and we're watching for this. Same way for Darcie and the community work, without you creating these fantastic models and micro solutions and, you know, and armies of people who can do things, saying things to Washington about what to fund at scale, and to be able to feed into CBO models to eliminate certain diseases within certain timeframes, are simply not going to work without the community infrastructure that you've put into place. And so it's exciting for me to be able to feature, you know, in one panel, including with the doctors, McCormick and Fisher-Hoch, all of these different parts of the ecosystem that need to be infused with this expertise of lived experience, of activism and advocacy, to be able to work on behalf of people. And so, yes, Dr. Flores, it should give people hope, but it also doesn't just happen. And Ysabel, you know, it doesn't happen quickly. So please tell us the direction from here.
Well, first of all, I think there are a couple of people missing from the set, and that is public health and federally qualified clinics, because they're expected to do the biggest lift. And in partnership with the rest of us, they can help make some of those massive changes. Because Yvonne, I appreciate that you're saying that every patient who goes into UCLA is going to come out with a genetic feed of what they look like and what their risks are like. We're
eventually. I mean,
eventually, that's not good enough either, right? Because we're fighting right now in clinics just to get Latinas BRCA genetic testing, you know, and counseling in their own language, because we now know the high level of breast cancer, not just regular DIS cancer, but the other hereditary and triple negative that is in the Latina community. And you know how we start to find all of that out, Donna? When we do subpopulation studies. Right. We cannot lump all Latinas into this one ball and expect that we know everything about them, just as we can't do that with the population. So I appreciate what Yvonne is saying when she talks about, we got to look at the Mexican population. It is a real a talisman for where things are going and how we have to address it. And how does it relate to the rest of our Latino subpopulations? Well, let us find out here, and then we can expand out and compare and contrast. So this is one of the things we've argued with the NCI. You need to drive, and with the FDA, you need to drive, allow, and promote subpopulation studies, or there will be consequences. And you know, Donna, this is the problem at the NIH. People check the box that they're including communities of color, but they're not held accountable when they don't deliver. And this is where we at the national level, and what I've been doing at the state level in our stem cell agency, we just created a check the box, uncheck the box, and you will not get funded, or you will not get this research funded if you're not showing us the proper inclusion and plan for dealing with racial ethnic minorities in this state. Because after all, they're also taxpayers and they're paying this bill. And so they deserve equal time and equal inclusion. So we sit at different tables, we see the master plan, we know the local needs, we pull them all together, we make the right people sit at the table to say, well, these are my issues. And the issues at the clinic level that I've been hearing are so freaking frustrating that they stop the woman from an early detection. And that is why we have late detection and high mortality rates. Because of some friggin' little codes in the clinic that they can't change or won't change because of cost measures, payer obstacles, government regulation. And so there's where we're trying to dismantle now. And I think that's what's great, to have all of these groups at the table with these different lived experiences, different knowledges, different research bits, different research bits in our hands, and
Mhm.
also the voice. We now have the voice that we didn't have before, and at all the
Abs-
tables.
I wanted to add to
Absolutely.
that one of the
Yes.
things that is important to us as a CBO is shoring up and fixing or adding to and making more robust the feedback loop for patients, right? And so what someone will say to a researcher, depending on the type of research, might be one thing, right? What someone might say to their doctor might be another thing. What someone might say to a community clinic might be another thing. And what someone might say to a community health worker promotora might be a different thing, right? So I think also appreciating that there needs to be so many different ways that people can express and give feedback on the barriers they're experiencing. And those also being very micro, right? So what a barrier is for someone who lives in Santa Clara County might be different from someone who's in LA, might be different depending on also like what subgroup they're in. So we have found that that there are holes in that feedback loop, right? In that feedback funnel that can be patched up by having multiple ways and multiple receivers for this feedback, but then also having a way for all of those, as Ysabel was saying, I'm getting this image around like everyone at this table. How are we sharing that information? Right. So if there are researchers getting information about what these barriers are, they might be published, but like how accessible is that? Do people know where to go? Are there big press releases when this is happening? There are medical providers also getting feedback through their regular patient feedback information, and they're getting it, and that's largely staying within their who their regulatory bodies are, and it's staying somewhere. And then as CBOs, we're getting lots of feedback as well, right, on a day-to-day, because we're helping people overcome the barriers to accessing health and accessing all of the things we're talking about. When are we all sitting at the table and talking about the feedback that we're getting? Because we're all getting different pieces of it based on the type of relationship and the type of trust that's built. And all of that feedback is really important, but there isn't real intentional space, I think, for these, like the grassroots feedback that happens to be in community with the research feedback that happens, and then also with clinical feedback that happens, or at least not enough intentional space, I would say. That
I think
really
that's it. There's absolutely not enough intentional space. I remember going to a summit for the PCORNet community research, so the Patient-Centered Outcomes Research Institute's research network of networks has allied with it all of the community or patient advocates that they work with around just clinical research. And for the first time, those community and patient partners to research coming together to do that type of feedback on, well, what worked for you or what didn't work? Are we seeing the same barriers, different barriers? I think that I know the PCORI meeting is coming up soon, and we'll share that, but that's not enough people know about that. And so I think I'm going to sit on that question about, where are these intentional spaces and how can we create more of them? How can we use both the technology that we have and the networks that we have to create more of those intentional spaces so that the learnings and the expertise of the community can be shared with researchers and we know that it's hit and actually creates change. Because that's my best definition of what patient-centeredness is. Did something change because of the feedback or involvement?
Absolutely. I think that's a wonderful idea. And it's something that I'm definitely going to take from this roundtable.
Yeah.
Great. So,
by the way,
yes, please.
I don't know. In fact, I mentioned it somewhat to Yvonne's, hopefully it's helpful, but also to you, Darcie. I don't know if you're familiar with the NIH's Compass grant. There was a funding mechanism that I kept saying to the folks that it says my colleagues, the ones I knew who went from UCSF to NIH MD, National Institute of Minority Health and Health Disparities. And I kept saying, CBOs need a funding mechanism apart from researchers in order to ask the community question. And so finally, the board of the NIH passed this grant mechanism called Compass that can be led by CBOs which I would always bring along, Yvonne, the researcher, to help guarantee. I've often said that researchers come to their community with logic models. The community uses logic and goes to work. So we're really trying to flip that, because, as you said, the community voice can teach a lot, but the researcher can help formulate that into a valid and validated answer that they can then take to the bank, right, to get more grants or to prove a point. So if we can flip this model using that kind of a grant mechanism, that'll be fabulous.
Absolutely, because I do think it is important to incorporate the community and its needs, especially when we're talking about deeply ingrained cultural values, like, how it is that we celebrate, how much drinking is involved, what types of food, how our diets are. I mean, all of those things, when no one's going to show up and be like, stop eating tortillas and, eating carnitas. That's just not going to happen. Don't eat tacos. So it's just, how do you learn to drink in moderation, eat in moderation, address all these other determinants that are way upstream that are causing unhealthy behavior in the first place. Do you know what I mean? So it's
mental health.
I think communities.
Right. I want to make another plug, right? I'm going to plug for mental health. I mean, it's so inaccessible, right? I mean, it's so inaccessible, and it's not considered primary. And so, we see clients every day who make impossible decisions and have been for years, right? Every single day are having to make impossible decisions. And so decision fatigue sets in, right? You have so many days where you're making really tough decisions about choosing between things. You have stuff going on in your community. You have so much that you're dealing with. So just a moment of relief or release, even though they might know that that's not the right decision for themselves and their health, like they understand that that's not a good decision, but day after day after day after day of making really impossible, tough decisions, I can understand how,
And I do not want to sound insensitive about like.
Oh no, I wasn't saying that, but no. I know you're not. I'm agreeing and thankful for you. Like, I think you are very, you've brought this up so many times during this, but I'm just very thankful for you creating the space to talk about how these behaviors are important and there's things that lead to them. So I thank you for bringing that up.
Absolutely. It's just sort of, how do we involve the community in coming up with solutions for how can we be healthier, even though we are dealing with so much. Yeah. Do you know what I mean? Like, how do we get where we need to be based on the problems that we have, right?
But Yvonne and Donna, this is really critical. Speaking of COVID, it ripped the Band-Aid off of this horrific healthcare system we have.
Right.
In fact, a colleague of mine said we can't go back to normal because normal is what got us here in the first place.
Right.
So, Yvonne, what happened during COVID was, in fact, and this is I think one of the positive outcomes out, is that a lot of communities of color also came to admit that they were emotionally stressed and that they did need mental health assistance. Yes. Something that we know in the macho world, this resilience can be both a benefit, a boon, and a bane in our communities, because we tough our way through things because that's the only answer we have when systems fail us. But on the other hand, they increase our risk. So when you don't admit that there's a cry for help, that you really need someone to talk to help share this trauma that you don't understand, but it really is making you drink too much, hit the wife. I mean, all these sorts of things, back to Darcie's point, all of these drivers that nobody really wants to admit to or recognize. And I think that we'll look down the pipe at our history. Sociology will write about it. Anthropology will write about it. And they will say there was a turning point as a result of COVID. Absolutely. So we either take the opportunity and run with it and make the best of we can, Donna, cry while we can and be really pushy, or we may lose this moment to make some really critical change in our communities, because I know they are addressing the mental health issue. They're recognizing it from the very top down. And what we need, once again, is to get those investments back into local communities to address the issue.
I hope you're right. I really hope you're. I love your hopeful. I live each day. I walk around the world equal parts hopeful and equal parts angry every day. Right? So I'm a hopeful person by nature, and I'm just really upset all the time around. And something that I heard from somebody I thought was really interesting about the pandemic was that there were no lessons learned.
I have
Really?
to disagree.
If you, I don't know how.
No, let me rephrase on what they let me get explanation of what they were saying. So I was at a conference and someone said there was no lessons learned from the pandemic, and they were talking in the context of the healthcare system, right? So not specific disease, but healthcare system. And the reason they said that was so many of the things were already known, and instead the pandemic kind of shone a light on these things that were already known. And so what she was trying to get from that statement was we have this opportunity right now to make these major corrections that we kind of already knew, right? And so, but for example, those of us who are in the space of, like all of us, right, of chronic condition and vulnerable communities or chronically ill communities, especially here in Santa Clara County, these types of things disproportionately impact the Latino community all the time. Like it's every time the same community is continuing to be impacted for the same reasons, right? Structural issues, systemic issues, socioeconomic issues, access to health issues. The pandemic comes along and it's like a mirror image, right, of what was already happening in the chronic condition space, what was already happening with other environmental disasters that we had here in the community as well. And so I love the way Ysabel phrased it around, like, do we look back, right, at this moment in time and say that was this big pivot, right, where we kind of like did these major overhauls, and we do see a lot coming from this administration around really wanting to put forward policies that overhaul these systems to make them more just? Or do we look back and we have another inevitable public health crisis or environmental crisis, and it's again the same communities that are disproportionately impacted both health-wise, economically, and others, and we haven't made with urgency those structural changes? And so I think the point that she was trying to make, clearly there were lessons learned, but I think the point she was trying to make was that we can't really act brand new about all of this stuff, right? That like there are things that we know existed in that already that were structurally wrong before, or that were systemically wrong before. And so that I think is the point that she was, so clearly there were lessons learned from the pandemic. What she was trying to make was that we are at a pivotal point.
There
and
are
we
no
want to
new
make
stories under the sun.
Yeah.
So I'm gonna need to, ladies, I'm gonna need to bring this to a close.
I do think.
Go ahead.
I mean, there might not have been lessons learned for the speaker. There might not have been lessons learned for us, but there were lessons learned for people who needed to learn certain lessons, who maybe didn't know what was going on and who were really clueless to the level of like disparities that were being experienced. Like, I really do think COVID shone a light on the hot mess that a lot of things were, and a lot of people's eyes were really opened. So that's the main lesson. I mean, I think it's like the takeaway. And I think now is really a pivotal time for us to sort of deal with the consequences of the consequences of the consequences, because there is things right now I do think are worse than they were before. I mean, speaking of like, you know, people are probably drinking more than they were in 2018, are having more mental health challenges, are, you know, having less healthy lifestyles. So things are just going to get worse if we don't do something about it now.
So now, as we bring this to a close, what is the one thing that you would like us and our audience to do? I don't want to even say think about or postulate, but to do to make things better moving forward. So I'll ask Yvonne, Darcie, and then give Ysabel Duron the last word, as she should always have. Yvonne.
Well, I'm sure we'll all have different ideas, but I'm happy I'm going first in case you guys were going to use mine. You know, like that's always a thing when someone says what you were going to say. So my main takeaway from this is that I really do think, and this again is not like something new, but I'm much more motivated and encouraged to actually do this, which is to create interventions having to do with how it is that we help Latino communities have healthier lifestyles, that look at the whole person, that take into account the impact and information from the community, and how it is that these interventions can be developed with input from the community so that they will be successful in the communities that we're trying to target, as opposed to researchers just showing up and being like, let me try this.
I love it. Darcie, the one thing out of many that
I'll just say, in case we don't get time, it's a real honor to be on this panel with Ysabel and Dr. Flores and our panelists who left, and to be moderated by you, Donna. So I just want to say I've learned a lot, and it's been a great honor. I, as an organization that is a grassroots organization, health is a justice issue, right? And so we would like people to view all of this through the lens of social equality and social equity, and to do the work and get involved in materializing and actualizing healthcare as a human right in this country. And so I know that transcends just liver cancer, and is more of a social call to action, but we are really, really invested in realizing healthcare as a human right materially in the United States for all people.
As a lawyer, a constitutional scholar, and a former federal prosecutor, I'll leave you that. I'll give you that social justice point and plus one on that. Ysabel, what one thing would you like us to carry with us moving forward?
Thanks, Donna, for the invitation. It was lovely to be here with everybody. I can't help but think that everybody needs to know that their voice is power, that they need to use it, that they not fear standing up, standing out, and talking, that whomever they can reach out to, whether it's their local representative, whether it's their state senator, whether it's their congressperson, they have voice, they have power, they have a vote. And only that together as a community can we actually exercise that power in a way that is going to change for us all of the things, so that Darcie can do the work on the ground and Yvonne can do all of the right research that she needs, so we can all do our jobs better and have a much more healthy community.
Amen.
Use your voice.
Thank you all so much for your brilliance, for your passion, for your legacies of hard work, for your partnership with me and the Global Liver Institute on these and the many, many issues we have. I know we are stronger together. And thank you everyone for listening and watching to this episode. And hopefully you will engage in the rest of this series. I can't say that they're equally as hot and fiery, but it's not as spicy, but I think you should watch. So I just want to thank our panelists and thank our audience and thank, of course, Team GLI and everybody who made this possible today. Be well.
Thank you very much. You too.